Atrial myxoma is a common benign tumor in the heart, arising from the endocardium. It can lead to various symptoms and complications, and its diagnosis and treatment are complex. This video will cover its details, including pathophysiology, diagnosis, surgery, and prognosis. The development of atrial myxomas involves abnormal growth and proliferation of primitive mesenchymal cells within the cardiac chambers. Mutations in various genes, including PRCAR1A and hormonal disturbances, have been implicated in this process. Dysregulation of cyclic adenosine monophosphate, CAMP, signaling is a key factor, contributing to uncontrolled cell growth and extracellular matrix production in atrial myxoma. Understanding the underlying pathophysiology is crucial for identifying potential therapeutic targets and developing novel treatment strategies. Atrial myxomas are believed to originate from embryonic remnants of the primitive endocardium. During cardiac development, certain cells fail to differentiate into mature cardiac structures and instead persist as undifferentiated mesenchymal cells in the atrial chambers. These cells can undergo further genetic mutations, particularly in the PRCAR1A gene, leading to dysregulated CAMP signaling and subsequent myxoma formation. Genetic testing and counseling play crucial roles in the management of atrial myxoma patients, particularly in familial cases associated with syndromes like Carney complex. Several tumor markers have been identified for the diagnosis and characterization of atrial myxoma. Immunohistochemical staining for markers like CD34, vimentin, and alpha-smooth muscle actin can help differentiate atrial myxoma from other cardiac tumors, such as myxoid sarcomas and cardiac fibromas. Additionally, these markers may provide valuable prognostic information, aiding in treatment planning and postoperative surveillance. Histopathological examination of atrial myxoma specimens reveals distinctive features. The tumor cells are typically stellate-shaped or spindled and are embedded in an abundant mucopolysaccharide-rich matrix. Unlike malignant tumors, atrial myxomas lack a true tumor capsule. Accurate histological diagnosis is crucial for distinguishing atrial myxoma from other cardiac tumors, as well as for determining the extent of surgical resection required. Atrial myxomas can present with a wide range of clinical manifestations due to their location, size, and mobility. Constitutional symptoms, including fever, weight loss, and fatigue, can occur, mimicking infectious or inflammatory conditions. The tumor's embolic potential may lead to stroke, peripheral arterial embolization, or multi-organ infarctions. Obstructive features, such as mitral or tricuspid valve dysfunction or left atrial outflow obstruction, can result in heart failure symptoms. Early recognition of these varied manifestations is crucial for prompt diagnosis and management of atrial myxoma. Diagnostic imaging plays a central role in the evaluation of atrial myxoma. Transthoracic and transesophageal echocardiography are the primary modalities, offering real-time visualization of the tumor, its attachment site, and its mobility within the cardiac chambers. Cardiac MRI provides additional information about the tumor's characteristics, including its composition and vascularity. CT scans are useful for evaluating the tumor's relationship with surrounding structures and assessing potential anatomical complications. These imaging modalities aid in accurate diagnosis, preoperative planning, and the assessment of tumor characteristics essential for surgical decision-making. Surgical resection, using approaches like sternotomy or less invasive methods, is the primary treatment for atrial myxoma. Off-pump resection and intraoperative transesophageal echocardiography offer advantages in preserving cardiac function and tumor removal. Understanding these techniques is crucial for patient care. Immunohistochemistry plays a crucial role in corroborating the histopathological diagnosis of atrial myxoma and differentiating it from other cardiac tumors. Specific antigens, such as S100 protein and desmin, are frequently targeted to aid in confirming the diagnosis. Immunohistochemical staining patterns can help distinguish atrial myxoma from other cardiac neoplasms, including myxoid sarcomas and fibromas, which may have overlapping histological features. Accurate diagnosis is critical for appropriate treatment planning and patient counseling. Despite complete surgical resection, atrial myxomas may recur in some cases. Incomplete tumor removal, with residual tumor tissue or microscopic extensions, remains a significant risk factor for recurrence. Additionally, familial syndromes, such as Carney complex, are associated with an increased risk of multiple or recurrent myxomas. Certain genetic mutations, particularly in the PRCAR1A gene, have also been implicated in recurrent cases. Identification of these risk factors is critical for appropriate patient counseling and long-term surveillance. Postoperative cardiac rehabilitation programs play a crucial role in optimizing outcomes following surgical removal of atrial myxoma. These comprehensive programs focus on expert-guided exercise training, risk factor modification, and psychological support. Rehabilitation aims to improve cardiac function, enhance exercise capacity, reduce postoperative complications, alleviate anxiety and depression, and promote overall well-being. Engaging patients in appropriate rehabilitation strategies is essential for achieving optimal outcomes and improving quality of life. The long-term prognosis of atrial myxoma depends on tumor characteristics and surgical resection. Complete removal has excellent outcomes with low recurrence rates. Potential sequelae include valvular regurgitation, atrial arrhythmias, and thromboembolic events, requiring appropriate management and anticoagulation therapy. The management of atrial myxoma necessitates a collaborative approach involving multiple medical specialties. Cardiologists play a vital role in the diagnosis, evaluation, and preoperative optimization of patients. Cardiothoracic surgeons perform the surgical resection, taking into account the tumor characteristics and the patient's overall cardiac status. Pathologists provide accurate histopathological diagnosis, while genetic counselors guide patients and families regarding familial cases and potential genetic implications. Effective communication and a coordinated approach among these specialists ensure optimal patient outcomes, individualized management plans, and long-term surveillance for potential recurrence or cardiac sequelae. In conclusion, atrial myxoma is a complex heart condition with diverse clinical presentations. Accurate diagnosis, surgical resection, and long-term surveillance are crucial for optimal patient care and outcomes. Collaborative multidisciplinary efforts improve our understanding and management of this pathology.